That was a fantastic setup for my presentation. It's almost like we planned this and coordinated for weeks. So thank you for that. You did a lot of the heavy lifting. And I've been asked to try to make up some time, so I will go a little quickly to tell you a little bit about what we've been doing down in Dallas. So I co-direct the Pediatric Demyelinating Disorders program with Ben Greenberg, and we have been at this now for quite some time. I'm going to tell you a little bit about our story and our research journey. But first I want to tell you what it is I do. People ask me all the time, what is neuropsychology? What is a neuropsychologist? So my field is really dedicated to understanding human behavior as it relates to central nervous system function, particularly when things go wrong. So we do a lot with folks who have brain-based medical problems. That's probably what we're best known for. And we do a lot of testing, our big batteries of tests to understand cognition, like memory, attention, and how all of those things affect a person in their daily lives. We also look at emotion, behavior, fatigue. So we try to take a very comprehensive approach to the whole person, including those medical factors, so we can best understand that individual and then provide the best supports to them. In pediatric neuropsychology, which is my specialty area, I kind of have an added challenge. We all do in this field, because the central nervous system is it's growing and developing and changing right before our eyes. So we really have a moving target, and we have to think about a medical problem when it affects the central nervous system. At what age did that happen? What was going on developmentally? How old are you today when I meet you, when you come in for your evaluation? So all of those factors will influence how I think about an individual case. So thinking about medical problems like the ones we're talking about this weekend, I take the approach of I look at the literature, see what we know about a given condition, and then I anticipate what problems a person that's coming to see me might have. So, we have this depiction here of an MRI, so I've reviewed the chart, and then I see this teenager who's a student and has to study and learn new things and go to school. But what I realize, and what we all know, is that each person is different, right? Each person brings to the table a whole host of factors that are really important. We've talked about genetics a lot already this week, their developmental history. Like I said before, when did this event happen? How has it impacted them since then? And the list goes on and on. I will highlight a few factors which include those related to social support, family, coping mechanisms, right? So whatever has happened, how has this person managed that? Our children and teens are incredibly resilient, but as Carlos pointed out, they have the right to experience the complex emotions that come with these experiences. So this is kind of the framework that we take. I will tell you, every evaluation I do is highly individualized when I do a full comprehensive evaluation. But when I do research, I'm describing a group of people. So I want us to all have that in mind as I talk about results from our research, that I am sort of describing groups of patients as a whole. But when we see folks individually, we're looking at these very detailed individual factors. So as I mentioned, we are down in Dallas at Children's Medical Center. We just celebrated our 10-year anniversary last month, so we've been open for 10 years now. We take a multidisciplinary approach in our clinic. We try to create a one-stop shop for our patients, and as we've all been discussing this weekend, we know that our folks with these rare conditions have complex needs, and they need all these specialists at the table, ideally working together to create the best approach to treatment and intervention. The vast majority of the folks on my list here, specialties on my list, are present at clinic with us each week. Some of those on the lower end of the list are folks we kind of have on call. They're up or down one floor from us, and if we need, say, a surgeon or urology, we can call them. So this is the approach that we're taking in Dallas. Here's a photo not long ago. This was Halloween. We don't dress like this every week, in case you're concerned. So I think Carlos touched on this nicely, as did Dr. Sadowski earlier. So why is this important? Why do we look at the whole person and consider all of these factors? And it really comes down to quality of life. For each and every patient that I see, my goal for them is for them to be as independent as possible, to be learning alongside their peers, to be participating as fully as possible. When it comes to the rehabilitation environment, we know that the factors around coping, fatigue are just extraordinarily important for them to get the benefit of that rehabilitation. So in my former life, before I came to Dallas, I was at the Kennedy Krieger Institute for my internship, and my job on one of my rotations was coming in and working with kids who were having trouble coping through their treatment, their rehab, the weaning off of event. So those are things that psychologists are very good at, is helping kind of address those barriers, treat those symptoms to make sure that our patients can participate and get the benefit of rehabilitation in school. So when we started this clinic, I had a bias toward understanding folks with very obvious brain-based lesions. This was, I was just starting out in this area, and you can see these lesions on MRI for kids with MS. It's also a chronic condition, and at the time we didn't know as much as we know a decade later about these kids, and we're still working in that area. But we thought that TM, transverse myelitis, would serve as a great control group because as opposed to MS, this is not chronic, and it's only affecting the spinal cord as far as what we can see on our MRIs. And so this was our very first step in learning more about these conditions. So early on, we had a study where we said, we're just going to compare MS and TM, and we're going to see how they do on all of these tests that I was mentioning earlier. For anyone in the room who's interested in the technical details of my tests, they're listed here, but I can tell you in summary, this battery of tests is about 45 minutes to an hour, and it was designed to tap into things that we believe are affected or at risk or vulnerable in the context of a demyelinating disorder. So attention, processing speed, fine motor skills, memory. So we wanted to get, just a quick snapshot of a broad range of functions. And so we administered this to, we had 18 with MS and 22 with TM. Small sample size, but for rare disorders, after about a year in clinic, we were pretty excited about these numbers. And so we hypothesized that kids with MS would struggle much more than those with TM on our cognitive measures, and that further, parents of kids with MS would tell us that their kids, their students, are struggling more at school compared to those with TM. So in some respects, we were right. We did see that our patients with MS struggled more on our cognitive tests. And some of these findings were statistically significant. But what really caught our attention was that these groups had the same rate of school problems. So about a third of folks with MS and those with TM were having problems in school. So we really pressed pause on our project for a moment and decided to switch gears and look a little bit closer at TM. When I talk about TM today, I want you to know over these 10 years, we haven't separated out AFM, acute flaccid myelitis. So when I describe the cohorts, they will be inclusive of AFM, and going forward, we hope to separate these out for research purposes. We did take a look at our clinical data at that time, and about 29% had been referred for a full evaluation. The significance of that is that they failed the screener, right? So they needed more testing. So that's a signal that something was going on, perhaps cognitively. The other notable detail was about 42% had been referred for some type of mental health service, individual therapy typically. So we published this paper where we simply described a cohort of kids with TM and what their cognitive functioning looked like. We also highlighted some things around the school problems that I've talked about, as well as parent report of attention problems and depression. So these numbers are really higher than expected for a group of kids without obvious brain-based problems. And we wanted just for this information to be out in the world, to put this on the radar of our colleagues. so that they could be tracking and monitoring these patients. But this left us, as research does, it leaves us with more questions usually than answers. So we have some questions we're working through right now, and I'm going to share some of our results with you. One of these questions we've been talking about for a little while now is, could there be brain-based changes in transverse myelitis that might explain what we saw and what we published in that paper? What about fatigue? Is fatigue playing a role? Quite possibly. In that paper that I described, we saw some overlap for the kids with cognitive issues and those experiencing fatigue. And then what about depression? We know this can have a profound impact on cognition. So tackling our first question, just briefly, part of the theory here would be related to the inflammation in the CSF that patients with TM experience. We don't see obvious brain-based problems when we do our clinical scans, but we wanted to think about this in a broader way. So we designed a study, and thanks to the TMA and Consano for helping us raise funds for a small pilot study, we were able to design with a lot of help from neuroradiology and the experts in that area. We designed a battery or a protocol that included imaging that we don't typically do on clinical evaluation that would help us take a different look at the brain. I will tell you that our analyses are underway right now as we speak. And in terms of something that we're seeing so far, we are not noticing any lesions in the cortical gray matter, which was something we wanted to specifically look at. So we had a cohort of kids with TM and their siblings, and we don't see lesions or major differences at this point, but we are continuing to analyze this data, and I hope to bring you more even before the next symposium. Regarding fatigue and depression, we had a dissertation student. He is newly Dr. Cole Haig. I wish he could be here with us. He came to the last symposium. He is off at fellowship at Boston Children's now, but his dissertation was studying the role of fatigue, depression, as well as other clinical factors when determining cognitive status in MS and TM. And I've listed his dissertation committee, including Dr. Greenberg there. So to set the backdrop for his research and some of the questions that we were able to answer, when I started out, I mentioned I was thinking of TM as our control group, right? Just with the similarities and differences it has with MS. And now I think of MS as really helping us better understand TM because we do know a lot about MS by now. So for MS and fatigue, I think Carlos talked about this. It's one of the most commonly and most debilitating symptoms reported in this population. So as many as 75% of adults with MS tell us about fatigue, and it really impacts quality of life. There's quite a bit of literature to show that. We know in our pediatric literature that pediatric patients with MS also endorse fatigue. With regard to depression, we do see high rates of that as well with MS. There are theories about, and even some research about, the role of inflammation and the biological bases for depression in the context of MS. About half of our patients with MS will have some type of psychiatric diagnosis. This tends to be an internalizing disorder such as depression or anxiety. So in this study that Cole Haig worked on, the goal was to evaluate and compare both fatigue and depression between MS and TM, and then just look at the relationship of fatigue and depression when it comes to cognitive functioning. So even with 10 years of data collection, you see our numbers here. We're pretty proud of these. This is a robust sample for rare diseases. So we had 67 participants with MS, 53 with TM. And for the things we're going to talk about today, we had the families or the parents, caregivers, complete ratings of fatigue as well as those that give us a sense of depression symptoms. And we also had them do that screening battery I showed you earlier. So in terms of our key findings around fatigue, there were no differences between groups when it came to all areas of fatigue that we evaluated. And it's one of the only times I've ever seen Dr. Greenberg seem, truly kind of stunned and like he was reflecting and processing, because he's been working with MS for a long time. And as we've said earlier in Carlos's presentation, it is very well established that for individuals with MS, fatigue is front and center. It's a prominent symptom that those patients struggle with. And Carlos also mentioned no one has really been able to study this and talk about rates of fatigue in TM. So this, to our knowledge, is the first study that was able to compare TM to a group of patients with MS to say there are no differences there. And when we took it one step further, just to compare to the norm, what we would expect in a normal population, both MS and TM groups had statistically significantly worse fatigue in all areas. And to give you a sense of the rate of fatigue, these numbers here reflect the elevations of fatigue for each group. So you can see that for that kind of general fatigue, feeling tired, and so forth, those rates were pretty similar. When you get to sleep, rest, and cognitive fatigue, you see MS has a bit more in terms of frequency of elevations in fatigue. But again, those were not statistically significant when we ran those analyses. And this is just a very big finding, I think, for our patients with TM. We always knew fatigue was a problem, but having data to say that and to put this out into the world, I think, is extremely helpful. When we looked at depression, similar to what we saw in fatigue, there were no differences between groups in depression symptoms. Another pretty eye-opening finding. There were also no differences from the normative mean, meaning that in our groups, our patients with MS didn't have more depressive symptoms than what we might expect generally, and neither did the TM group. To give you a sense of the rates of elevated depression, it's about a quarter for each of those groups there. But there's more. So we used a fancy model with a lot of support from statisticians to come up with an indicator of cognitive impairment, and it was using that battery I showed you earlier. So we were able to actually come up with rates of cognitive impairment, and we did see a statistically significant difference between MS and TM, as we would imagine, such that MS has a more frequent rate of cognitive impairment. And then something that I think is really important to note, we ran an analysis that told us that those who were cognitively impaired were more likely to have elevated fatigue symptoms, which might make sense. So then, as the last step, as the grand finale to this project, we wanted to look at what factors predicted cognitive status in these groups. We took all of these patients, all of their data, into one model, and we did account for the diagnosis. In this model, we entered in fatigue, depression, how old they were at onset. For reasons I mentioned before with a developing nervous system, there is some literature to suggest age at onset matters. Time since onset, how long have you been living with the condition, and then an indicator of physical functioning. The one thing that was kind of associated with the cognitive status was depression. And this probably doesn't shock too many of us, really just as human beings, and understanding that if we are in a low mood state, we're not as sharp or good cognitively. But also for those of you who follow literature in MS and in other areas, we have a lot of literature that shows associations between depression and cognitive status. In this case, greater depression symptoms increase the likelihood of cognitive impairment in our cohort. So, the takeaways. I know that I did not touch on all of the conditions that we are discussing at this meeting, but I did want for this audience to know that we have data now to suggest that any individual with a CNS demyelinating disorder is considered to be at risk for neuropsychological difficulties and the things we've been talking about today. But very importantly, not all are affected. So I don't want the message to be that, if you have a condition X, you're, you're destined to have these issues. Not at all. And this is why we study this. This is why we report on the rates. And when we can report on a group of patients and understand their rates, it tells us what we as clinicians can look for, what all experiencing these conditions can also kind of self-monitor for. And then it gives us some ideas about intervention. And that's really the critical piece. So in thinking about who might be a candidate for an evaluation, we would say that those, the person themselves, the people who know you best are in a great position, as well as your treatment teams, to kind of help you decide if an evaluation makes sense, where you could get some answers to questions about cognition, mood, fatigue, and so forth. I think a great way to kind of test if now is the time to have an assessment is this kind of functionally impairing? Are any of the things we've talked about today really interfering with the things that you want to or should be doing? And then a primary physician can place a referral, or someone from the medical team can do that. And so you know what it looks like. I get a lot of points when I walk in a patient room and say I'm not a medical provider. I don't use needles. So there are no needles, no medical equipment. An assessment with a neuropsychologist is a lot of talking, a lot of those tests I mentioned, a lot of paper, pencil, question, answer, some things on computer. There's a record review, and then, perhaps a diagnosis is relevant, but many times it isn't. And it's really a matter of identifying strengths and weaknesses, areas for opportunity with regard to intervention. And, ideally, we're using strengths to address any problem areas. The great thing that comes out of an individual assessment is that you have a tailored treatment plan that is very specific to what's happening with you right now, and then there are opportunities to follow up to track progress. And so a few words here, there are a lot of things, and Carlos touched on some of these as well. The good news is, for all of the problems that we've discussed today in this presentation, we actually have some really great options for intervention, a lot of tools available. I would encourage everyone to think about going all the way back to the basics. When we're struggling, going back to basic things like sleep. Think of sleep as the foundation to a house. Without sleep, I've sent people away from my office. I say we can't test if you haven't slept, or you're having trouble with that. And so, we want, I think the research shows 7 hours at minimum, hopefully more than that each night. I know that's easier said than done, but there are a lot of ways to address sleep that a specialist or provider could work with you on. We've mentioned cognitive behavioral therapy in Carlos's talk, so we have some very great evidence-based therapies to address depression, anxiety, even the fatigue symptoms. We've talked about exercise. So we want to think about the things that promote our wellness, the things that serve us, and that's going to be different based on the person. Some people like yoga. Some people think that sounds like a nightmare. So it really depends on the individual. I'll move ahead here. As we've been saying this weekend, we are stronger together, so connecting with the community. I don't need to tell this group that, but I just participated in my 9th camp with the TMA in July, and there is something so powerful about camp, about this symposium, about coming together and hearing about others' stories and experiences. And I can tell you it enriches my work and the work of providers to hear these stories and to be in a retreat-like setting with all of you. So I really want to acknowledge all of you, all of my patients and families who share their stories and who talk to us about it and who teach us what we need to know about these conditions. The Transverse Myelitis Association has been great to me, has become an extension of my own family, and it's just an honor to stay a part of such incredible work. Children's Medical Center has been a huge supporter of our clinic, as has UT Southwestern, And then I want to acknowledge my team. We have several of those folks here. I get to see them every week in clinic, and they really make all the difference in what we're able to do for our patients. I did include my schnauzers. They've become the unofficial mascot for the clinic. I think we have 4 schnauzers between the team. So, but thank you. I'm happy to take a couple of questions if we have time. Nope, don't have time. I lucked out.